All right, everyone, this is your lecture on shock, which is in chapter 14 in F.A. Davis. So essentially, when we think about shock, I want you all to be thinking about a state of decreased oxygen to the tissues. So we need oxygen in order to function. So if we have shock, this is something that would be life-threatening because we are not able to get adequate amounts of oxygen to the tissues. So we're not able to function the way that we need to do. So essentially, just it doesn't matter what type of shock we're talking about, but we have a state of hypoxia in the tissues. So that is an imbalance that we don't want to see. And if we don't immediately treat this, we're going to result in organ system failure and death. So we have to think about cardiac output, we have to think about oxygen delivery, consumption, and oxygen debt. So when we talk about shock, I want us to remember our hemodynamics. So just very simply put, remember that hemodynamic monitoring is an invasive monitoring. Maybe we're going to use an arterial line and we're assessing the pressures and flow of blood within the circulatory system. So it's like checking the vital signs of the cardiovascular system so we can see how it's working. So again, our hemodynamics could include our blood pressure, cardiac output, and again, remember our cardiac output is the amount of blood that's being pumped by the heart every minute. So that is going to help us determine how well the heart is actually functioning. In regards to our central venous pressure, that again measures that pressure in the large vein that leads into the heart, into that vena cava. So when very simply put, when I'm thinking about central venous pressure, it's a gauge. I'm thinking how much blood is returning to the heart and how well the heart is able to pump it back out to the body. So this can help us again determine if we're pumping enough blood to the tissues. If we're thinking about systemic vascular resistance, because that's another hemodynamic that is affected with shock, we're thinking about how much resistance the blood encounters as it flows through that systemic circulation. So the blood vessels throughout the body, except for the lungs. So we're thinking about the blood vessels like pipes, and our SVR is like the narrowness or wideness of these pipes. So when the pipes are narrow, we're thinking high SVR, it would be harder for the heart to push blood through. So the heart would have to work harder. On the opposite end, this can happen when blood vessels are constricted or when there's buildup of plaque inside the vessels. Okay. So then on the other hand, if we have low SVR, the pipes are wider. So it's easier for the heart to pump blood through because there's not as much resistance. So this can happen when those vessels relax. So maybe I gave a vasodilator, it relaxed it. So now it reduced that SVR. So again, this can help us determine how well the heart is working and if there's a problem with constriction or dilation in the heart. I have included questions throughout this in presentation throughout the PowerPoint. These are the connection checks that are actually directly in your book. So I encourage you to take a second and try and answer this. The question is, the nurse understands which of these increases as the delivery of oxygen to the tissues falls below the tissue's requirements. Write this down, see if you can answer this, and the answers are in the back of your book. So I want you to try and check continuously, take a break and try and answer these as we go. So we're going to cover different types of shock. We're really going to focus on hypovolemic shock, cardiogenic shock, obstructive shock, and distributive shock as we go. There are 4 stages of shock, which you do have to know the stages as we go along here. So again, each stage is categorized by specific clinical manifestations. So we're going to see specific cues in each one. And without treatment, shock is going to progress through these. So the earlier we identify someone is in shock and we initiate treatment, the better the possible outcome that that client is going to have. So if we're in the initial stage of shock, we're going to see hypoxia because we're not getting oxygen to the cells. So the symptoms, the cue could be subtle. We might not see much, but there is some cellular damage that is occurring. There might be a change in heart rate. An invasive hemodynamic monitoring is going to show a decreased cardiac output. And if we don't identify this, shock will progress to the next stage. One of your earliest things to kind of tell about worsening conditions related to hypoxia is an alteration in their level of consciousness. So as this progresses, anytime we see a change in their LOC, we are concerned about oxygen delivery. So that could be something that you would see first. In regards to the compensatory stage, we're going to see everything is trying to make up for what's going on. So now all these mechanisms are going to start to initiate because they recognize that decrease in oxygen. So we're going to maybe see now they're tachycardic. Maybe now they're breathing fast. They're tachypnic. Their blood pressure, though, might not be influenced just yet. It may have a low but normal blood pressure, depending. And they are going to start having decreased urine output. So remember, you always assessing urine output in relation to shock. Remember, our kidneys are one of the first organs that blood is going to be shunted away from. So anytime we see oliguria, or we're concerned. So as we start to progress into the progressive stage, now things are failing. So those compensatory mechanisms are not working. They were attempting to maintain that blood pressure, but we just are continuously, extensively shunting blood away from organs. So now we're not getting good blood flow peripherally. So, and if we do not identify it now, they're going to be they're going to start to have worsening metabolic acidosis. We're going to see electrolyte imbalances. They're going to develop stages like respiratory acidosis. And it will continue into this refractory stage, which is just they're still not getting oxygen. So now we are going to see cell death and multi-system organ failure, which we're going to talk about. So if we're seeing multi-system organ failure, the likelihood of them surviving this is going to be very small. Now they're in that aerobic metabolism because they're not getting oxygen, and it's irreversible at this point. So they're most likely going to pass away if we can't get into this. So initial stages, again, might be subtle changes that we kind of see, but we're getting that decreased oxygen is starting. So I'm thinking maybe they're seeing a change in their level of consciousness. Once they move through that, which they probably will, into that compensatory stage, now we're going to see them being more restless. Maybe now they're confused. Their heart rate is elevated. They're breathing fast. They're in respiratory alkalosis. Their urine output is decreasing. They might be hyperglycemic. The pulses are going to be weak because that blood is being shunted from the peripheral area. So when you're checking for a radial pulse, maybe it's weak. Their bowel sounds are going to be decreased, again, from that shunting of blood. Their skin might be cool. It might be a little moist. Now, we want to catch it in that stage. If you don't, now they've moved on to that progressive stage. So now they might be lethargic or in a coma. Do you see how fast that can progress? Now they're not making urine. They're anuric, A without. Now they're having dysrhythmias, hypotension, they're cold. Now their pulses are either absent or they're weak. They're in a absent bowel sounds at this point. They could be severely acidotic. And yeah, they're not going to do well. So if you really don't treat it now it's going into that irreversible stage, which is the refractory stage. Severe hypotension, they're going to be in a coma, renal failure, hepatic failure, peripheral tissue ischemia, necrosis. So again, the likelihood of them making it through that is very, very low. So it's irreversible at that point. So again, here's another little break for your mind. I want you to try and answer this. The nurse monitors for which clinical manifestations in the patient in compensatory shock? So go ahead and try and figure this out. So again, we want to quickly determine the presence and extent of shock. We need to monitor it. We're doing our hemodynamic monitoring. We're going to be drawing labs. We're going to be seeing how the patient physically is looking. So now we're going to get into the different types of shock. So we're going to start with hypovolemic shock. Okay, so if you want to follow along, again, this is chapter 14 in your textbook. So if we're thinking hypovolemic, we're thinking volume. Hypo's low, volume. So I'm thinking we do not have fluid. We're losing it somehow. And this is most commonly from our trauma or our GI bleeds. So we're going to see that they don't have enough fluid volume to maintain cardiac output. So again, maybe just a big loss of blood. So an acute bleed, blunt traumas, maybe they're severely vomiting, maybe they're having really severe diarrhea, fluid loss due to burns. Those could all lead into hypovolemic shock. So again, we have a decrease in fluid volume. So we're going to have decreased cardiac output, which is ultimately going to lead to decreased tissue perfusion. So we're not getting oxygen to the tissues. So initially, what's going to happen, again, we have that acute loss of volume. So your heart is going to try and compensate with that. It's going to increase the heart rate. It's going to try and pump blood through to increase the cardiac output. So that sympathetic nervous system is going to try and stimulate epinephrine, again, to try and increase that contractility of the heart to get it pumping. So it might initially have that blood pressure and cardiac output. We're trying to increase those. So we're redirecting blood flow at this point if we're bleeding from non-essential organs to vital organs. So they're trying to shunt blood to the heart, to the brain. So again, if we think back to those stages of shock, the symptoms are going to depend on the level of shock that the client is in. So initially, they may not have, again, any symptoms at all. They might appear normal. They might be awake talking to you. You're trying to control the fluid volume loss, right? So in the early stages, again, that blood pressure might be normal, might be a little bit high, depending, but the heart rate is typically increased because it's trying to compensate for the loss of fluid. As that progresses, the patient might present as restless, confused. Our urine output is going to decrease. We're going to become pale, cool, clammy. Pulses are going to weaken, and our cap refill is going to be sluggish or slow. They're probably going to be hyperventilating. You're going to see respiratory alkalosis. The bowel sounds are going to be decreased. They're going to be hyperglycemic because, again, it's a fight or flight initiation. So we're producing glucose in that initial compensatory phase of shock. But as it progresses, we're going to see more symptoms. So you're thinking lethargy, hypotension. Their skin's going to become colder, anuric again at this point, maybe absent pulses, dysrhythmias. And if we don't, again, identify and treat this, they're going to enter those refractory stages of shock. So coma, severe hypotension, cold necrotic extremities. If we think back to our hemodynamic monitoring, um, in we're going to be assessing those. We're going to see decreased central venous pressure. We're going to see because we don't have that fluid volume there. So their oxygen set is going to be low. Okay. And that we're going to see an increased SVR. If we see that, it's showing we're trying to initiate those compensatory mechanisms at that point. So I have your symptoms here. So again, we want to catch this early. Always looking at the urine output, always assessing our skin, our pulses, doing a glucose check, checking the respirations. Their level of consciousness, getting an ABG, right? Putting in a Foley, checking the kidneys, right? As this progresses, now they're going to have multi-organ dysfunction. So how do you think that we're going to medically manage this? Well, we need to give them fluid back. So we're trying to resuscitate this client. We're trying to maximize their oxygenation. We're giving them fluid. We're identifying the cause and we're going to treat it. So again, maximizing oxygenation is always an essential treatment. So your immediate priority is their airway. So put them with a high flow oxygen, 100% non-rebreather. Might be if they're able to protect their airway, they may have to be ventilated and intubated. Maybe we're going to do a BiPAP or a CPAP, depending, and you're going to give rapid fluid resuscitation. That is the mainstay treatment for hypovolemic shock. So if it's non-hemorrhagic, if they're not bleeding, we're going to probably do normal saline, right? 0% 9 normal saline boluses. You just want to be giving them fluid. Possibly you could give them lactated ringers if needed. We usually will do trauma patients with like if they are losing frequent blood, we're going to also give them blood products. You might give them fresh frozen plasma and platelets if they're bleeding. You really want to be monitoring their MAP for this. So I'm looking at that mean arterial pressure. I want to keep it, in this case, right around 50 rather than 65 or greater in bleeding, because we're trying to reduce any type of clots from being dislodged, because they may have started to form to stop the bleeding. So whatever the cause of the trauma was, we need to treat it. So we're trying to stabilize their blood pressure, improve their peripheral pulses, get their extremities warmer, get a Foley, monitor their urine output, monitor their neurostatus, their LOC. We would be checking lactate levels because that shows that tissue is not getting oxygenated if they're in a period of anaerobic metabolism. So that can be shown with the lactate. So you are checking a lactate level. So again, the fluid resuscitation, this is evidence-based practice. If we give increased morbidity and mortality are documented with the use if we give too much crystalloids in trauma resuscitation. So resuscitation with large volumes of normal saline has been shown to worsen the metabolic complications associated with hemorrhage. Most noticeably, coagulopathy and altered pH resulting in acidosis is seen, negatively affecting survival. A simple solution of stocking trauma bays with 500 mLs of normal saline rather than 1,000 mLs was found to decrease the volume of normal saline infused during resuscitation. So again, really be monitoring their response. We can always give too much of something, so we just want to give the right amount. If bleeding or loss of fluid is obvious, priority is to identify and control it. So again, if they're coming in and we can't immediately see them bleeding, maybe we're going to do an ultrasound and a focused assessment to determine if blunt trauma, if their trauma patient has caused like intra-abdominal bleeding. We're going to probably do X-rays, CT scans to determine the presence of fractures because those could cause bleeding. And they may have to go to surgery to locate and control the source of bleeding if that is the problem. If it's fluid loss from vomiting or diarrhea, then we want to treat that. So don't forget to be doing your neuro assessments. Any decreased level of consciousness could occur because we're not getting good oxygenation. So you are always checking their LOC, we're checking their vital signs, their hemodynamics. Again, tachycardia might be initially present. If they develop hypotension and bradycardia, then we're not effectively compensating. We're going to see decreased cardiac output, decreased CVPs, our urine output is going to decrease. Initially our skin's going to be cold and clammy. Um, and if we're treating it correctly, all of these things should be reversing. So again, we want to decrease that lactate level. That would show us that we are adequately oxygenating the tissues again. So that's actually something that we really want to see is that lactate change. So our ABGs, initially, they might be in that respiratory alkalosis. Again, remember they're hyperventilating initially, but if we're not treating it and it's getting worse, they're going to develop metabolic acidosis because of that anaerobic metabolism that's happening. Um, we are checking their venous oxygen saturation, right? That SVO2, we're going to see that's decreased again because that is an indicator of oxygen delivery and they're not getting oxygen. Their H&H, that hemoglobin, hematocrit, those values are probably going to be decreased if they're bleeding. We definitely want to do a metabolic profile. That's our renal failure, liver failure, right? You'd see that BUN is going to be high. That's kidney problems. Creatinine is going to be high, kidney. And if these are worsening, again, we know that we're getting in those later stages of shock. Lactate, again, increased lactate, it's going to show we're not getting good perfusion at the tissue level, at the cellular level, I should say. So we want to see that level decreasing. That would show we're adequately resuscitating the client. So you're going to put on your 100% non-rebreather mask. Oxygenation is always our number one priority because they're not getting oxygenated. Anticipate intubation, right? Remember from prior modules, you're not the one intubating, but you have to get the stuff and you have to be prepared for intubation with them. Maybe you get that rapid intubation sequence kit there. You have the rapid response, you have the team there. You're all prepared for that. You need to get the IVs in right away, large ones. We want a couple IVs when we're talking peripherals in a trauma bay. You need at least two 18 or 16 gauge IVs. And you're going to give the fluid replacement as prescribed. So you're going to do the fluid, normal saline, lactated ringers, if they tell you to do that instead, blood products. Again, fluid replacement is the foundation of treatment in hypovolemic shock. So we need to give the fluids. Little mind break. Here's another connection check for you. The nurse understands which patient is at risk of developing hypovolemic shock. I want you to think about that, write it down. I have another one, hemodynamics. The nurse understands that which hemodynamic parameter are consistent with hypovolemic shock. I want you to pause, take a break, answer this. And now we're going to get into cardiogenic shock. I do just quickly want to remind everybody when you're studying these concepts, you have to think about what are we trying to see now? So again, if they're bleeding, I obviously want that bleeding to stop, and then I would see those outcomes improve. So maybe their SVO2 is now normal, their lactate's normal. So again, we're trending things, we're trending the cues and assessing improvements. That's how we know we're adequately treating the shock. So please write down any questions about hypovolemic shock. Now we're going to move on to cardiogenic. Luckily, we have semi-covered this already in your cardiac lectures, but we're going to go over it one more time, okay? Remember, if I see cardiogenic shock, I'm thinking acute myocardial infarction. Again, I'm thinking my male clients, they're more common because of that coronary artery disease. But the incidence of myocardiogenic shock is higher in females after an MI. So the mortality rate of this is kind of high, it's 50%, but it's even higher if they're older than 75. So we do have to consider their age. So again, it's usually caused from MI. So what am I thinking about when I'm thinking cardiogenic shock? Well, I'm thinking that I'm having an inability of my heart to pump. So essentially, I'm not getting perfusion because my heart is not able to contract and adequately pump blood to the tissues. So have a really severe reduction in my contractility. My heart's not strong enough. So that ejection fraction, that percentage of blood that's pumped out, is markedly decreased. So your cardiac output is decreased. So again, that is going to lead to your oxygen saturation levels decreasing. And that happens at the tissue level because that decreased cardiac output. So if this continues, we have complete heart failure, essentially. We're going to have really profound hypotension and we can develop pulmonary edema. So if I'm thinking cardiogenic, I'm thinking, well, how are things going to start to compensate? And in this case, my sympathetic stimulation is going to occur. That's why your heart rate is going to initially increase because I'm trying to get more blood to the tissues. So what we're going to see here, it depends. You're really going to see similar symptoms to them having acute MI. So they may have chest pain, diaphoresis, that sweating, nausea, vomiting. And as the cardiac output continues to decrease, you're going to see hypotension. So now we're getting into the compensatory mechanisms. So now we're seeing a decreased level of consciousness. We're seeing decreased urine output, poor pulses, pale. Doesn't this ring a bell? It's very similar to the stages of hypovolemia in this stage. Cool skin, decreased bowel sounds. Maybe they're short of breath. We're hearing that fluid in the lungs, those crackles. And that would be related to that pulmonary edema that can happen. So if this again is going to lead to that decreased oxygen at the tissue level, so you have anaerobic metabolism happening. So we're going to see a lactic acid. So those are going to be high. ABG wise, you're going to see metabolic acidosis. And if this continues, now those symptoms are even going to be more pronounced. So now we're seeing profound hypotension, bradycardia. Now our organ systems are going to start to fail. So you're going to see worsen function in the labs. Our liver enzymes might be bad. We're going to see kidney problems, essentially renal and liver failure. If this continues, they're going to develop in a coma. They're going to be cyanotic. Their skin might be mottled, right? Now, again, we're not having bowel sounds and anuria, no urine. So our SVR in this case is going to be very high and our cardiac output is very, very low. Your venous oxygen saturation, again, is going to be low. Again, your symptoms. So what do you think you want to do? Well, if we're thinking MI, again, you're always thinking a 12-lead EKG, cardiac enzymes like our troponins, right? Because we're trying to see, are they having a heart attack? And a chest x-ray. Again, that initial diagnostic for cardiac for MI is always that EKG because you're trying to rule out that. Cardiac enzymes are going to also be done, your chest x-ray, because you might be able to see if it's a cardiac tamponade instead or a tension pneumothorax. You want to rule those out. And it's going to show if they do have pulmonary edema. So our treatment for cardiogenic shock, well, we need to start our drug therapy to increase blood pressure and cardiac output. And again, you may have to send them for an emergent PCI or a balloon pump. So again, when I'm thinking of my balloon pumps, we talked about these before, right? So I'm thinking about the monitoring. Again, this is going to be an ICU patient. This is not going to be somebody on a general unit if they have a balloon pump. Um, but remember that that intra-aortic balloon pump is going to help get cardiac output out. It's working for the heart because the heart can't pump. So it inflates before dystole and it deflates right before systole to help decrease the work on the heart, to help it work a little bit better. Remember, that is not permanent. This is while we're de-stressing the client and getting them stabilized. So the other thing, again, you're always thinking oxygen, so we want to stabilize that. We would give them 100% oxygen through a non-rebreather or intubate if we needed to. And then I'm thinking of my medications to help with vasoconstriction, which are your vasopressors. So I'm thinking dopamine or norepinephrine. That would be initiated to increase my blood pressure and maintain that mean arterial pressure. Um, Again, you do have to make sure that they are still getting fluids if we're starting them on a pressor because we don't want the vascular system to just collapse. Um, Typically speaking, I know we're thinking some of you might be thinking nitroglycerin as well, but that needs to be very carefully added because again, it dilates. So we don't want to decrease the blood pressure any further than that. And it's the same kind of stipulation with diuretics. We'd have to use those very cautiously because I don't want to decrease volume at the same time either. Morphine may be administered again for multiple reasons if they're having pain, but it is also a vasodilator. So in a good way, it does decrease that preload. But again, we have to make sure that they're able to sustain their blood pressure. But regardless of which medication you end up initiating, you have to have that arterial line so that you can continuously monitor their vital signs. Um, there is a good chart in your textbook 14.5 that goes over again these medications that a lot of you are confused about. So again, which one is your inotropic? So I'm thinking which drug? And if I'm thinking my vasopressors, which drug? I still want you to be able to connect those together. Um, so it does list like your dobutamine, dopamine, epinephrine, remember, is a bronchodilator slash vasopressor. And on any of these, we have to monitor their hemodynamics. Here it is. Again, maybe I'm going to send them to the cath lab. I would do maybe a balloon or a stent. I'm going to open that up just to see the coronary artery if there's a problem with the blood flow there. They could place the stent to keep that patent open. And again, maybe I'm going to do the balloon pump. Your assist devices also might be necessary if everything else is not successful. And that again is just that mechanical pump that assists the pumping of the left ventricle. So that would decrease that work of the heart as well. So it would displace blood from the left ventricle and eject it into the aorta. So that could be also a temporary mean to help with the heart. Your assessments here are identical, all shock. This is what we're thinking. That decreased LOC, because I'm not getting cardiac output. I'm thinking maybe hypotension, tachycardia, because I don't have good cardiac output. That respiratory rate is going to increase. Looking at my hemodynamic monitoring, my breath sounds. Again, I could have crackles because of that pulmonary edema. The urine output is going to decrease. Cool, clammy skin. Initial ABGs, I might see that respiratory alkalosis because I'm breathing fast. And as it continues, I'm going to develop metabolic acidosis because of that tissue oxygenation that's being deprived. So your SVO2 is an indicator of inadequate oxygenation at the tissue level. That's going to be decreased. And if this continues, you're going to develop renal and liver failure. And your lactate is going to be elevated. So I want to see a decreased lactate to show that I'm starting to adequately perfuse this client again. So again, what am I going to do? Well, I'm going to give them oxygen. I'm going to prepare for intubation. I'm going to give them maybe my vasoactive meds like norepinephrine or dopamine because that produces vasoconstriction. So that's going to increase my blood pressure. Maybe I do an inotropic med like dobutamine because that increases the contractility and cardiac output. It makes the heart pump better. I might do a diuretic, but again, very cautiously to decrease that vascular volume if those filling pressures are very, very high. So that would have to be determined by the physician. Maybe I would do morphine to help with any pain that they're having. But again, you would want to use it cautiously, but it would help decrease like workload of the heart. So it could help. You're going to give fluids as prescribed, but again, cautiously to increase cardiac output if filling pressures are low and if they're not having signs of pulmonary edema, because we're thinking breathing. I want to restrict their activity because I want to decrease that cardiac workload. So that is a reminder on our cardiogenic shock. So if I were to pose another question to you right now, if the nurse were to correlate which of the following hemodynamic parameters to the patient with cardiogenic shock, would they have decreased afterload, increased contractility, increased cardiac output, or increased right atrial pressure? So again, pause me, rewind that, see if you're able to answer that question, and write down any questions that you have on cardiogenic shock. The next class is obstructive shock. So this is essentially, we're thinking of an obstruction. I mean, let's just be very simple here. So essentially, there's a mechanical barrier of some sort, and it's really affecting cardiac output. Something is getting in the way and it's increasing the afterload. We're not able to get rid of the blood. So as in, it's the same kind of thing if I'm thinking cardiogenic shock. My symptoms are going to be independent of fluid volume status because I'm not necessarily bleeding. So that mechanical obstruction to the pumping of the heart is what is the problem. And so I'm getting decreased cardiac output, poor perfusion at the tissue level. And so the pathology really is going to depend on what is causing the shock. So if I have a pulmonary embolism, which could cause an obstructive shock, then I'm thinking something happened, a DVT, it moved, right? And now I resulted in obstructive shock. So in that case, you'd have really high afterload because there's a thrombus there. So the blood's not able to come out. So in those cases, like the alveoli are ventilated, but they're not getting perfused. So remember back to that VQ mismatch, we're severely mismatched in those cases. If it's due to cardiac tamponade, again, we have excessive pressure on the heart, and that's because all that fluid is going to fill in that pericardial sac. So that could be from a trauma, and maybe we're bleeding around it, or there's a really large uncontrolled pericardial effusion of some sort from a trauma. So all this fluid's accumulating around it, and now less blood is going to enter the ventricle. So we're not able to fill or empty appropriately. So again, the symptoms are going to depend on what is causing it, but your clinical manifestations of decreased cardiac output are all going to be the same. So I'm still thinking decreased level of consciousness, decreased urine output, poor pulses, pale, cool skin, decreased bowel sounds. They're all the same. It doesn't matter what type of shock it is. But in these cases, maybe they also have chest pain. Maybe they also are nauseous and vomiting, or they're short of breath. Because again, and think about your classic signs of cardiac tamponade, because that could be causing this. So I would think of the muffled heart sounds. I would think of low blood pressure and maybe signs and symptoms of right-sided heart failure. So your JVD. Um, Hemodynamics, we need to still be doing our hemodynamic monitoring for them. Maybe they have that PA catheter, that Swan's catheter. We would want to do an arterial line. But in these cases, your SVR is going to be high. Cardiac output is going to be low, and our venous oxygen saturation is going to be low. So this is starting to look very similar to everything, isn't it? Our actions here. So what do you think we need to do? We need to get them oxygenated. So again, 100% oxygen. Prepare them for intubation. give them their medications because that cardiac output's low. So again, I'm thinking my vasoactive meds, I'm thinking norepinephrine, dopamine, because again, those are going to produce vasoconstriction. So now I'm increasing the blood pressure, and that will help allow the patient to stabilize until definitive treatment is implemented for what's causing the obstruction. If it is a cardiac tamponade, what do I need to do? A pericardiocentesis, right? I need to drain that blood from the heart. That would relieve the pressure immediately, and that would let the ventricles fill normally. So you would maybe be anticipating them going to the operating room. Um, maybe if the obstruction's severe, that might be what they have to do. And we've learned about pulmonary embolisms as well. What do we do for those? Well, anticoagulation, right? So I would think heparin. So again, anticoagulation via heparin, I could do because that would decrease the formation of new clots. That's not going to break up an existing one though, right? Right. That's just going to help prevent new ones. So I'm thinking it's going to help decrease the formation of new clots, prevent the existing clot from getting any bigger. Or you could do thrombolytics, those ones that end in ACE, right, to dissolve the clot. Maybe they even have to go to the OR and they could remove the thrombus through a thrombectomy. So these are all your same symptoms. But again, just in this case, they might have signs of right-sided heart failure as well. Again, you still always are assessing your neuro status, vital signs, urine, skin, because they have that altered tissue perfusion. So again, their neuro, they're going to have a decreased level of consciousness because they're not getting good cardiac output. They're going to be hypotensive, tachycardic. The respiratory rate is going to increase. Um, the filling pressures are going to be variable depending on the cause. So their hemodynamics might be different. The urine output, though, is going to be low, cool, clammy skins. Again, they might initially be in respiratory alkalosis because they're hyperventilating. So if I were thinking of my evaluation of care outcomes, well, I need to see if I can quickly identify the obstruction and maintain their blood pressure, then that is definitely going to help their chance of survival. So I'm trying to figure out if this is a PE, is this a cardiac tamponade? What was the cause of this obstruction? Get their blood pressure, their cardiac output improved, and we could effectively treat obstruction shock. So please write down any questions that you have about obstructive shock. That one is a little bit shorter. The next one's distributive shock, and this encompasses three. So a distributive shock, this includes sepsis, anaphylaxis, or neurogenic shock. So, but essentially all of these are a result of a disease state that really causes really poor vascular tone and vasodilation. So this results in all this venous pooling. So even though you have blood volume, there's a state of relative hypovolemia because we're not getting venous return to the heart. Sepsis is the most common cause of widespread vasodilation and distributive shock. This is what you normally see in sepsis. But anaphylaxis is another type, and that again is related to the histamine, and that results in vasodilation. The least common form is neurogenic shock, which is usually an injury to the brain or a spinal cord injury. So we will talk about that as well. So again, it's a disease state. We have really poor vascular tone and vasodilation. So we're pooling. So we're not bleeding, but it's a relative state of hypovolemia because our heart is just not able to pump appropriately. So if we get into neurogenic shock, sad, neurogenic shock is sad. And this is usually, again, a spinal cord injury, or maybe they had a response to regional anesthesia, or they have a brain injury. And it does happen in 20% of people that have a C-spine injury. So it is very uncommon in patients if they have lower than that injuries, because again, our airway is monitored like from really your thoracic spine up. So any type of cervical injury, you're always worried about their airway. So when this happens, there's severe disruption in the sympathetic nervous system, essentially. So that vascular tone is significantly decreased in this. So they're just they're not able to vasoconstrict at all. And that's why those blood vessels are so relaxed and dilated. So it's just not returning to the heart. And that is what relative hypovolemia means. So the problem then is made even worse in this case because the heart's unable to compensate. It's not able to even try and pick up in this case. So they are not tachycardic. They are actually in a state of profound bradycardia. So that is one thing that makes neurogenic shock a little bit different. So they are also, though, in a state of anaerobic metabolism. They're really, really susceptible to orthostatic hypotension as well. I had a client, he had just retired from being a police officer. He was a police officer for his whole life. It was his first week of retirement. He was out in the garden, and he stepped on a garden hoe and it hit the back of his neck. And he was completely paralyzed from his neck down. And he essentially went into a state of neurogenic shock, and with that orthostatic hypotension, what a lot of these clients require with a spinal cord injury is you have to ACE wrap all of their legs really tight before you move them at all, because that hypovolemia gets so bad, that state of imbalance, because their sympathetic nervous system isn't able to work. So that was one patient I can still never get out of my head this many years later. It was really, really sad. But you are thinking spinal cord for neurogenic for sure. So in these cases, this patient looks different than my hypovolemic, cardiogenic, or obstructive client, because in these cases, the skin's actually warm. They're flushed, and that's because of that vasodilation that happened. So they still have decreased cardiac output, but in this case, they have a decreased systemic vascular resistance. So they do look different than your other clients in that case. So in this case, you want to provide, again, that cardiovascular support. You're trying to resolve the primary cause of the shock, though. So when I'm thinking of this, I'm thinking cardiovascular support. I'm going to do fluid resuscitation cautiously as much as I need to. I'm going to use my vasoactive IV meds like dopamine or epinephrine. If necessary, I need to treat that bradycardia with atropine. Again, maybe if it's really severe bradycardia, I have to transcutaneously pace. They might need ventilator support through intubation. So again, these manifestations are different. So the patient's going to have decreased cardiac output because of that vascular tone. However, they are usually bradycardic. They're not going to be tachycardic, and they're going to be pink flushed. So you're going to be doing your hemodynamic monitoring. You're going to assess the cardiac output. You're going to see CVP and your pulmonary arterial pressures are low because of that decreased venous return, and your systemic vascular resistance is going to be low. Your respiratory rate may also be low because of the injury that caused neurogenic shock, if it's a C-spine injury. Again, so that would decrease the oxygen levels as well. So what do you think that you want to do for this client? Well, we kind of talked about it. You're going to give fluids cautiously. We're just trying to match the vascular space with that dilation because they still have fluid volume. We want to give them the vasoactive drips. We're trying to increase that vasomotor tone. We may have to give atropine, again, if they're bradycardic. You might have to pace them. If we are moving them, we have to raise the head of the bed very slowly because of that loss of systemic vasomotor tone. They're, again, very vulnerable to position changes. So you do want to also do prophylaxis for DVTs. So I'm thinking my SCDs, maybe heparin, because these clients would be at a high risk for venous thromboembolisms if it's a spinal cord injury. So a mind check here. The nurse understands that which of the following are clinical manifestations of neurogenic shock. And this is a select all that apply. So please pause this and see if you can figure this one out. The next one is anaphylactic shock, which you all probably are familiar with. If I'm thinking anaphylaxis, I'm thinking an allergy, right? I'm thinking this is a really bad hypersensitivity to something. And I got that histamine release. I'm also thinking when I think of anaphylaxis, I'm thinking of that IgE, that antibody that is released when I am allergic to something. So anaphylaxis, um, what else comes to mind if you were to think about this? Well, I am thinking repeated exposure. So again, that's those IgE antibodies. The more I'm exposed to something, the more I might produce those, and that is what can end up causing an allergic reaction. And again, life threatening for this. So your common allergens are things like food, maybe seafood, or medications like antibiotics. I'm thinking my penicillins, right? Everybody's allergic to penicillins of some sort. So in these cases, this is really rapid, right? This is a rapid onset, and it's usually their airway is what's compromised. So it's because of the swelling. Your tongue might swell, the airway is swelling, and in this case, they're still having a circulatory collapse because of that widespread vasodilation that happens in distributive shocks. So we do have decreased cardiac output as well in anaphylaxis. But in these clients, I am thinking they could have that shortness of breath, tachypnea, they're wheezing, stridor, they're cyanotic. And if we do not treat anaphylaxis, they will go into respiratory arrest. They still will have things like tachycardia, hypotension, their skin can be cool. And they, again, are also really vulnerable to orthostatic hypotension because of that vasodilation. You will see skin changes if it's an IgE or histamine reaction, right? So that red, itchy skin, angioedema, which is like when their mouth swells, it's a deeper swelling. So they could have the edema around their eyes and their mouth. You see that rash right here. It's pretty diffuse and widespread. It's not like a localized rash. It's not a localized reaction. It's pretty widespread. So the treatment for this is you have to remove the trigger. Like if it's my t-shirt, I'm allergic to the laundry detergent, I need to take that off right now. So if it's a bee sting, right? I remember my brother was stung about hundreds of times by bees. And he was with my other brother, and my other brother ran away because he was also stung. And my older brother was just laying there getting stung by bees. He was dying. And a neighbor saw him and had to remove him from the bee stings. If it doesn't matter if you give somebody epinephrine but you don't remove the trigger, you're not going to fix the allergen. So you have to remove that trigger right away, whatever is causing it first. So if, like, for example, you guys are all going to be giving blood transfusions. If my patient all of a sudden develops allergic reaction to the blood, I need to stop the blood right now, right? That would be your priority thing with an anaphylaxis. If it's a bee sting, you have to remove the bee sting. You have to remove those, the stingers if they're still in there. But it could be unknown what caused the allergy. So the removal might not be possible. So you may have to make the patient vomit. I'm sorry, you wouldn't want to make them vomit. You might have to do like a suction, a tube or something. So, but IM epinephrine is your treatment priority. This is intramuscular, and that's preferred because it's a consistent, rapid rise in that level, in that therapeutic concentration that we want. And it doesn't give as many complications IV. So that is why we do it IM. So you can repeat that dose 2 or 3 times. Most patients are going to respond to the IM injections, but if they're not, then we may end up switching them to IV epinephrine. But IV epinephrine in general is just going to promote that bronchodilation. So it's helping the airway. It's going to relieve that respiratory distress that's happening. And it's also a vasoconstrictor. So it's going to aid in restoring blood pressure. The second priority in this case is assessing the airway. We're going to maximize oxygenation through the initiation of oxygen. So you're going to give them 100% O2. If we need to prepare for intubation, we will. If we need to give them IV fluids, we will. Other medications we commonly use for anaphylaxis are things like antihistamines, corticosteroids, and inhaled bronchodilators, like our albuterol. So again, remove the trigger right away, give them IM epinephrine. You can repeat it a couple of times if needed. Then you would give them oxygen. Then you would prepare for intubation. Then you would put an IV. Do you see this is a little different than your other shocks? I need to give them epinephrine right away first. So please, if they do have anaphylactic reactions to something, that has to be documented, right? Because we don't want to give that allergen ever again. So that is a true allergy to something. So that education in this comes a big play, because if we are giving someone an EpiPen, we need to teach them how to use it, because we want to avoid anaphylactic shock, right? So if they're known allergy is peanuts and they eat it because they didn't know there were peanuts in that recipe, we want them to know, use your EpiPen right now. So the educational piece comes into play for that. The last thing that we talk about is sepsis and septic shock. So if you do have any questions on the other two distributives, please write them down. So you are all semi-familiar with the term sepsis, at least, or septic shock. So, but if I am thinking sepsis, I do want you to think that this is life-threatening. In the United States, a lot of people die from sepsis. A lot of people die from infections. So, most of these incidences are actually increasing. We have our aging population. We have much sicker patients at this point. So, more patients are on chemotherapy or immunosuppressants, and all of that puts these clients at risk for developing sepsis. So there are different definitions. We're going to go with sepsis, that it's a life-threatening organ dysfunction caused by a host response to the infection. If we develop septic shock, that's when we're getting profound metabolic abnormalities. It's progressed at this point. These all are worst case scenario with sepsis and septic shock is that it goes into something like disseminated intravascular coagulopathy, which is DIC, or multiple organ dysfunction syndrome, which is MODS. Those are our worst case scenarios if we do not identify sepsis and treat it fast. So we're thinking infection, right? We're thinking there's something going on with the immune response. We're trying to identify the antigen. So all of these things happen. And there's different pathways for everything depending on what is going on. So this is an example of one. I would love for you to pull the policies at your clinical sites for the septic protocol, because a lot of them have certain symptoms that might be seen, and then they might say, oh, they actually meet criteria, SIRS criteria. Are we concerned about an infection here? And that is based off of evidence-based practice. So in this case, they look at, are we suspecting organ dysfunction? Do we think that they're in sepsis? Okay, this is what you're going to do. We're going to draw this. Oh, now they're in septic shock. This is just a pathway. And again, they all could look a little bit different depending on where you are. But essentially what we're having, we're just getting all these complex responses by the immune system. So initially, we're activating an immune response and it's non-specific. So we're just trying to go to the area that's causing the infections, and we're going from there. We're producing fibrin. We're trying to localize that invading organism. At this point now, things are dilating, and all these things, they're causing like local blood vessels to dilate. So we're getting more circulation to that area that we're concerned about, because now we can get those immune cells there. And that is what causes that local redness, warmth, and edema in a site of infection. So we're trying to invade and kill that organism there. We're trying to keep it localized. But if we couldn't keep it localized, that's when we develop something like sepsis. It's not just to one system anymore. So the response becomes amplified at this point. It's uncontrolled. So it's not normal anymore. We're producing all these inflammatory cytokines. Everything is impaired. So it results in damage essentially to the blood vessels, and that results in that mass vasodilation. We don't have a good vasomotor tone. We're leaky at this point. So now we develop sepsis and septic shock. All of that pro-inflammatory cytokines overpower all these inflammatory responses. So now it's systemic. It's not localized anymore. So that is the problem with sepsis in general. It's not localized. It's now affecting everything. So it's still a distributive type of shock. So that is why you're still going to see poor vascular tone and vasodilation in sepsis. So you're pooling blood in the venous system. So we have blood, but we're in that, again, that relative state of hypovolemia with this, because we're not able to get it where we want it to go. So septic shock is divided into early and late stages. If we have an early stage of septic shock, that's like warm sepsis you might hear in the hospital. That's when we're seeing that initial inflammatory response. So that is when your patient's tachycardic with bounding pulses, they're warm, flushed skin, and they have a temperature. So that is where your SIRS criteria might pop up on your EHR. If their heart rate's high, maybe then it will alarm you. It'll say, do they also have a fever? How are their vitals? So if you meet certain SIRS criteria, then you have to notify the provider, because we're trying to prevent this systemic problem. If we don't, so say that we ignored that SIRS criteria, they were tachycardic, they did have a fever, but you didn't report it, because the blood pressure might be normal. So maybe you just missed it, or you didn't get notified by the home health aide. So those would be like our early stages, but now it's getting late. So that's your cold shock. And that's when they develop coolness, they're pale, they have weak, thready pulses, they're cold at this point. They're still tachycardic, but their blood pressure is low. So if we don't treat this, this is where they get that end organ dysfunction. So now they might have that lethargy, coma, anuria. So they can get very, very sick. So again, our early and late stages. You're thinking that poor vascular tone, vasodilation. Again, we have blood volume, but it's not being pumped to where we want it to go. Our filling pressures, our CVP, they're going to be low. Our SVR is low, again, because we're vasodilated. Our oxygen levels are going to be temporarily increased, because initially with their increased cardiac output, but that's going to drop. So they're going to develop into that cold state. And ultimately, that oxygen levels, we're going to have inadequate oxygenation to the tissues. So how do we identify that our clients are in sepsis or septic shock? Well, again, depending on the findings that you're going to see, you're going to do like signs and symptoms of infection. So a fever is going to be huge. You're going to be looking at the white blood cell count. How is their blood pressure, their respiratory rate, their heart rate? And again, you might have specific signs of infection, like if it's a bladder infection, it hurts when they go to the bathroom, maybe their breathing hurts. So I still would do urine testing. I would do blood cultures. We would do imaging procedures, maybe a chest x-ray to see if there's pneumonia that's going on. We want to identify where the infection is coming from. So remember, you have these bundles, and it needs to be done as soon as we identify that someone might be in sepsis. So you're trying to prevent this. And again, I just want to say that hand washing is your primary way to prevent infections. So we want to also avoid that overdoing things, right? We want to get our patient off the ventilator. I don't want them to be over ventilated for 2 weeks. Their chance of pneumonia and sepsis increases with all of that. So they created these bundles that are saying, hey, you need to do all of this as soon as you suspect that your client is in sepsis. So within 1 hour, I need to try and do this if my patient meets this criteria. So what I need to do is give them fluids. So what you're doing is you're trying to give like a one-to-one fluid replacement based off of their weight with normal saline, those crystalloids, normal saline. You need to get lactate levels. If it's over 2, then we would diagnose someone with sepsis or septic shock. We have to give them broad spectrum antibiotics, but you cannot give them antibiotics until you get all of your cultures. So don't forget that you have to get sputum cultures, urine, and 2 sites for blood, right? Because you're assessing for gram-positive and gram-negative organisms, and you can't give them antibiotics before you draw cultures because you're going to mess up the results. So anytime we have sepsis, our goal is get the cultures ASAP and give them fluids based off of their weight. I cannot start the antibiotics until I give them until I get all the cultures. I have had situations where it's very difficult to get maybe a sputum. You might have to have respiratory come up and induce a sputum culture. They should have a Foley. You're probably going to have to replace the Foley and get a new urine culture when you change the Foley out. So you want to give the antibiotics within an hour of identifying the problem. So it has to be very fast. If their blood pressure is low after giving them fluid, then you might have to give them vasopressors. We are trying to keep their MAP above 65. Usually they might do lactated ringers, that crystalloid solution LR. Um, we usually will try and give it over 3 hours to keep that blood pressure stable, but we want to make sure we're tapering off the fluids once we find that the client is getting stable. Okay, and antibiotics again, once we get the culture results back, that's when we could give them more specific antibiotics, but we always have to start them with broad spectrum first. If we don't treat this, again, here are the problems that we might end up seeing. I don't want you to forget about things like stress ulcers also, because all of my patients in the ICU could develop a stress ulcer because they're going through a lot, right? So anytime they have the stress ulcers like in their GI tract, again, you're probably going to do the H2 blockers, PPIs, all of these patients would be on those. Um, that's like the least of my worries, but that is still important. I need to make sure that I am treating them for stress ulcers. I don't want them to develop a GI bleed on top of this. So with DIC, ooh, this one is most commonly caused by sepsis. This is when you see it, and it's because all those coagulation factors are really influenced. Um, and there's 2 different phases of this as well, and they will start to bleed out all over the place. It's very, very interesting. So all this blood clotting happens through the body's small vessels, and at the same time, there's reduction in clotting factors and platelets. So it's like we call them microclots are happening with this. So initially, they're clotting all that. They have this excess production of fibrin. So again, these microclots are being formed. Um, and that causes ischemia and necrosis of those extremities because of all those clots. So you'll look at like the tip of their nose and it's black, or their fingertips and they're black. And that puts them at risk for having a stroke or a pulmonary embolism as well. After that, they start to go into a phase of fibrinolysis, which is when they're trying to break and remove those clots. So now they're bleeding um, all over the place and they can't clot correctly. You're going to see their dimer levels are going to be high. Their platelets are going to be really low. Their PT, their clotting factors are really prolonged and they're excessively bleeding through any orifice that they have. So it could be their IV site, it could be a Foley catheter, their nose, their ear, their mouth. So we need to treat this right away. We try and treat the sepsis, obviously. You have to treat any of the symptoms that they might be having, the bleeding. We're going to give them crystalloids like LR, blood replacement, and we're going to replace those clotting factors with FFP platelets. We don't use anticoagulation normally for this because, again, they're already at risk for bleeding. So that is usually how you will treat DIC, but we also need to make sure that they have bleeding precautions in place. So again, using a soft bristled toothbrush. We don't want to do peripheral blood draws on them. We don't want to do IM injections. We would need to make sure that they're on stool softeners, electric shaver only. We're really again thinking it's a term called consumptive thrombocytopenia. It's just consumptive. So our treatment again would be to give them FFP platelets. Another thing to call those is those cryoprecipitate infusions. Those are the clotting factors. It's a blood product and it contains those fibers that help with clotting. And if we were to give this patient platelets, remember how you transfuse platelets. You do give these faster than blood. So the platelets are normally over 15 to 30 minutes. They're very fast. You still need special tubing for those. You don't warm it. It should come up from the blood bank still. So it's a little bit easier to give this than it is blood in terms of how fast you give these. So this is an example of what DIC looks like. You can see all that bruising, that terrible. So I do have a little connection check right here for you that says the nurse understands that which of the following indicates the initial phase of DIC. So I do want you to see if you are able to answer this. And then we are getting into our other problem that we could see, which is multiple organ dysfunction syndrome. This is a complication of sepsis, and this is really, really bad. We are not getting oxygen to the tissues, and essentially our cells can be programmed to die in this case. So it's really accelerated in sepsis. It's called apoptosis, which is when your programmed cells die. So it's widespread. This is systemic, and it's all due to that increase in inflammation and permeability. So this is just really, really bad oxygenation. So the mortality rate for something like this is very, very high. And this usually is also associated with acute respiratory distress syndrome. They develop ARDS, which we remember is that fluid in the lungs. And this leads to your kidney system, the hepatic system, the GI system, all of these failing. Um, if we were to develop a failure of 3 or more systems, the mortality rate almost like triples. It's almost a 90% mortality rate. It can be 100% mortality rate if the cardiovascular and neurological systems are involved. So the focus of MODS is supportive. We're trying to control the infection. We're trying to maximize oxygenation, restore any type of fluid volume that's lost. So we would need to give antibiotics and fluids. If they do have low hemoglobin, we would have to give them blood. You would have to mechanically ventilate if they have ARDS or problems with their lungs. So really your primary nursing diagnosis with this would be altered tissue perfusion because you're not getting cardiac output for this. So the neuro assessment, everything, all of this is still the same as if I was talking any type of shock. So they're still going to have that decreased level of consciousness. You're still going to be doing their vital signs, my hemodynamic monitoring. They're going to be hypotensive again. You're going to be assessing their urine output. It's going to be really low. Their skin color, cap refill. They could be bleeding again because my mods can be also in DIC, so they could be bleeding from everywhere. You're going to be checking the lactate because again, increased lactate levels is going to show that my tissues are not being oxygenated. So we need to adequately normalize those. And this is just a reminder, I'm meticulously washing my hands to try and prevent sepsis so that they're not going into multiple organ dysfunction where their mortality rate is going to go up to 90%. So I still need to get my blood cultures from 2 sites. I need to give antibiotics. I need to do good mouth care, fluids, keep the MAP above 65. And this is just a reminder when I'm assessing my central nervous system. Again, one of my first signs might be that altered level of consciousness. As it progresses into restlessness, confusion, it might progress into lethargy and coma. Initially, with a cardiovascular system, it might be normal at first. So blood pressure, though, is a valuable indicator of fluid status and my cardiac output. So if I have a decrease in my blood pressure, I'm thinking there could be a problem. So I'm going to be assessing my pulses. I'm looking for that anytime I'm thinking my compensatory stages of shock. I'm thinking, how's my blood pressure? How's my heart rate? Tachycardia is typical finding because of that sympathetic nervous system. I'm always assessing my respiratory status. This will help me determine like the level of progression here. So early stages of shock are usually I'm breathing fast, tachypnea. I'm trying to increase my oxygenation. EBGs are going to be done. This, of course, is going to be a clear indication of poor perfusion if my urine output decreases. It's common. It's one of my early signs that I'm developing a problem of some sort because I'm not getting blood flow to the kidneys. I'm going to have hypoactive bowel sounds, nausea and vomiting might be pregnant. The GI system is very vulnerable to poor perfusion. They even say in some cases that if I'm not getting good blood flow in the GI system, then I could develop something like a systemic inflammatory response, and that could preclude them to developing something like MODS. So remember, if I have my ICU patients, they could be very, very stressed, and I want to decrease those risks. So that is why you always see someone with a PPI or an H2 blocker in the ICU, just to reduce that risk. Here's just some charts that I put in as a reminder. So you do have to be able to identify on all of the shocks, what are my lab findings that I'm going to do? What are my clinical manifestations, the cues? How could I tell if my client is developing into the stages of refractory shock at this point? What are my specific treatments that I need to do for this? Again, my lactate levels, I'm always going to be checking those. What does that mean? And I just included some other charts with the hemodynamics. I have it ended with another connection check. Please try and actually do those. There's also a really good revolving case study in chapter 14 that starts from the beginning and goes all the way to the end. I do encourage that because that does do more of an application type thought process. I mean, that really concludes shock. I think you have to be able to identify the types of shock, the symptoms that you might see. How are you going to treat this? Um, but a lot of them are very similar when it comes to the treatments, but what's very particular with one? So I would make a list of, we have the shock blank sheets in the announcement. I think that's a good way to kind of organize your thoughts. And please write down any questions that you do have, and we will do some activities in class.